Thank you for inviting me to speak about this new product, this exciting new product, especially now that speaking about Albrecht orthosis has become synonymous with functional rehabilitation and not just supporting a joint statically anymore. My background is in physiotherapy and also biomechanics. I have worked in an orthotics clinic as a physiotherapist in the past. So it's always interesting looking at new products, but then also evaluating how they can help somebody during their rehabilitation process. So I decided I didn't want to speak extensively about the anatomy of the shoulder joint and what subluxation is. Just briefly to say that normally, as you know, the glenohumeral joint is having the whole of the humerus is supposed to be sitting into the joint. In this occasion, you can see what we call the subluxation, where the head of the humerus has slipped downwards. And this is usually a result of weakness of the rotator cuff or other muscles, and also perhaps looseness of the joint. There's different types of etiology for the subluxation of the shoulder. Traumatic is quite common in some of the sports, especially contact sports like rugby and other ones. Also sports where you have repetitive shoulder movements, especially with the hand in outstretched position. You also have non-traumatic disorders where the muscle control is over time is reduced. This can be very commonly after injuries of the rotator cuff. And finally, the neuromuscular causes, which are perhaps the majority of those patients with subluxation. Stroke is, of course, one of the most common conditions that would lead to shoulder subluxation. In fact, up to 80% of patients with stroke will develop shoulder subluxation, usually in the early stage after the stroke. But also it's common in other conditions like cerebral palsy, brachial plexus injury, traumatic brain injuries, and so on. It's important, of course, to remember that stroke, if we look at the European level, talking about 1.1 million new strokes every year, with about 10 million survivors across Europe, with long-term effects at any one time. So you realize that we're talking about potentially a huge population of people who may need to have some kind of management for subluxation. There are different types of management. There's surgical management. And again, as we heard before, there's always different criteria about who might or might not be a good candidate for surgical treatment for somebody with a subluxation. And then you have non-surgical conservative management. Therapeutic exercises are given very frequently. Positioning and strapping can help. Electrical stimulation has also been proven to help with a lot of the patients that have subluxation, as well as orthosis. So talking about orthosis, there are all kinds of different types. For many years, the most common type of orthosis for somebody with a subluxation would be some kind of splint, sling to support the weight of the limb. So the idea there was simply to stop, obviously, the humeral head from slipping out of the joint by supporting the arm. And this, obviously, it can still be used in many cases, but as we are talking more and more about functional rehabilitation and orthoses that actually help to assist function and rehabilitation, then especially if you're talking about your typical stroke patient, then you have to question what repercussions this would have into other aspects of this patient's management in terms of muscle tone, function, pain management, and so on. And since we are talking about a very large number of stroke patients, I think it's important to always think about those and take them into account. Obviously, some of those slings, yes, they would do the job. They would support the humeral head and stop it from subluxating, but with potentially detrimental results in terms of the function and the rehabilitation of the patients. Then you have other supports like the ones you see here for either unilateral or bilateral application. These types of supports have been also in the market for many, many years. If you think about those those stroke patients that have specific advantages because you then have, you start having functional ability, so you have potential for rehabilitation while you're wearing those. I think some of them for many years have had issues with discomfort. And you have to remember that potentially a stroke patient might be wearing one of those for basically the whole day when they're awake and they're up and about. Yes, in those cases, effectively you're trying to apply forces through the skin to hold the arm and the forearm into this corrected position. But then you have to start thinking about the shear stresses through the skin. And again, if you remember that a large majority of those patients will be stroke patients, typically elderly patients with comorbidities, then you also have to take into consideration what those shear forces might do to their skin over time. So more recently, different types, like you can see on the right side, different types of orthoses have been developed which take into account the conical shape of the forearm. And of course, the whole idea there is that rather than simply applying tension, therefore shear stress through the skin, you're taking advantage of the conical shape of the underlying skeleton of the forearm. And then by having a conical shape support for the forearm, you can start suspending the weight of the arm. Again, some of those supports have been on the market for years. But then again, you start having other issues that are coming in. When I was working as a physiotherapist in an orthotics clinic, one of the first things I learned is that you can have sometimes some really, really clever devices, some very expensive devices, that can do a lot of things, but if the patient can't use it, and if the patient doesn't find it easy and comfortable to use it, then sooner or later, whether it costs 500 euros or 5,000 euros, it will end up in a cupboard somewhere and never be used again. So we're then talking about compliance issues. And it's important to remember that when we're talking, again, if you think about those stroke patients, we're not just talking about compliance of the patient themselves, but you have to think about the whole of the care team that will potentially be helping those patients on a daily basis, whether that's their carers or the family or perhaps nursing staff in a nursing home and so on. It is important for them to be able to use it as well. Otherwise, again, it will not be used, or at least not effectively. So there's been a number of different issues with these types of orthoses over time. And even simple things like ordering and stocking. Again, it's very easy to say, oh, we'll make 30 different codes, so we'll always have a code that will fit somebody. But of course, you then have to think, well, how easy is it for a clinic to hold an effective stock to fit every single patient that will walk through the door? I don't know about here in Germany, but in the UK at least, in some cases, the whole orthotic department is basically a little closet. So that's where the assessments have to take place. That's where the stock has to be stored. So even just telling somebody that, yes, we have a great product, but you need to have, even just to have one of each, you need to have a whole cupboard full of products just for this one type of patient. Can be a problem. So similarly, you can make it too difficult to measure somebody and decide which one of all those different sizes you need from different codes. Occasionally, the braces can actually simply be very difficult to adjust and to fit, to the point that you need specialized orthotists maybe to fit those products. Whereas in many cases you need the nursing staff or the therapists to be able to fit them quite easily. Donning and doffing can be an issue, like I said before, for either just the patient or maybe also the carers. Obviously, instructions is a very important thing here, to have clear instructions. It's surprising how often we see really, really nice products that are aimed to be used by people with neurological conditions, with probably cognitive impairments. And nevertheless, the whole instruction manual is just 3 or 4 small photographs with tiny letters that the patients can't even read properly. And then, of course, you have to think about function. And again, like I mentioned before, we're really happy that so many new orthoses by Albert have come synonymous to functional rehabilitation. But you have to think that with some of the other types of orthosis, if you start restricting movement, restricting function of somebody, this can actually have the exact opposite effect. So you may be managing well the subluxation, but you might be taking the whole rehabilitation process backwards instead of forward. And also, of course, because you do have, even with your typical stroke patient, you have so many other comorbidities and functional problems lower down in the upper limb, in the hand, in the wrist, and so on. It is increasingly important to be able to combine an orthosis like that with some kind of wrist-hand orthosis that will help patients in their function. Solutions, obviously, the fewer amount of codes and the variations you have, the better. So universal right and left can be a game changer, and also few sizes and codes as possible. Because, like I said, in many cases, people in a stroke unit or in a clinic will want to hold the stock to be able to feed 3 or 4 or 5 patients in one go. So the fewer codes they need, the better. Similarly, has a few measurements as possible, so there's not so much room for making mistakes. Clear instructions, and the clear instructions not just for the clinician who will fit the orthosis, but also, like I said, importantly, for clear instructions for the people who will be using the orthosis on a day-to-day basis, whether this is the user, the patient themselves, or the carers. Easy for the carers to apply, like we've already mentioned. Ideally, single-handed application for stroke, for hemiplegic patients, and I think that's really, really important. And I'm aware that sometimes it's just not possible. But I think where it is possible, it is important to try and make it as easy as possible for somebody who has only one hand function to don and to doff. And similarly, it's really important, if we're talking again specifically about the stroke patients, to have products that don't encourage the position that as therapists we want to fight against. So again, you may have a product that fits well, that is nice, it's doing the job, but if it's going to encourage somebody to bring their hemiplegic side, hemiplegic arm into this typical internal rotation, adduction, and forearm pronation with no control of the wrist, then again that can be very problematic. And ideally, obviously, not apply restriction to movements of the elbow and hand and wrist. One more time. So this is the omosan, which, of course, you're going to see in more detail in a minute. I just briefly wanted to go through some of the features of this nice new device. So it is universal. It can be used on either the right or the left side, and it does have only one size. So it's something that you can use obviously very, very easily with so many different patients of different shapes and sizes. It has the usual high quality materials that you're used to seeing in Albrecht's products. It has the clasps which make it easy to don and doff, and also easier for people with single-handed function to operate. And also you have the two vertical straps which allow somebody to apply different amounts of offloading for the glenohumeral joint. On top of that, a very good idea that Albrecht decided to apply these anchoring points so that this can also be used as a support for people using the CTS, the wrist hand orthosis, and perhaps in future other orthoses as well. Which again is really important because for many of those patients that would potentially benefit from having one of those orthoses, the added weight can actually create problems. So then you can hopefully alleviate them with those. So this is it from me. Thank you very much.
So, wir haben jetzt eigentlich schon alles gehört, was eine Schultersubluxation ist, wo es herkommt, was man dagegen macht und was es dafür gibt. Also wurde eigentlich alles gesagt. Aber wir gehen jetzt nochmal speziell ein bisschen auf die technischen Details ein von der omosan und machen so einen kleinen praktischen Teil, wo wir einfach nochmal an den Patienten zeigen, wie man sie anlegt, wie man sie auch selber anlegen kann, wie man sie einstellt, dass wir was zum Herzeigen haben. Ich erkläre es noch mal ganz kurz ein bisschen, wie die omosan aufgebaut ist. Und zwar, wir haben ja einmal ein Schulterelement und ein Unterarmelement, ein vorderes und ein hinteres Zugband. Dann haben wir natürlich, dass die Schulterorthese nicht von der Schulter rutscht und auch da ist, wo sie bleibt. Den Gegenzug unter der anderen Seite, unter der Achsel, sowie einen relativ großen Klippverschluss. Der ist aber dazu da, das werden wir nachher sehen, dass man auch die Orthese wirklich selbstständig mit einer Hand öffnen kann, dass man niemanden braucht, man braucht keine Pflegekraft. Das ist wirklich dann selber auch nur mit einer Hand, die ich ja in dem Fall habe, möglich. Dann haben wir oben ein bisschen auch mit Farben gearbeitet, dass man die omosan genau positionieren kann, dass sie genau mittig auf der Schulter aufliegt. Wir haben auch ein Band eingenäht, das nicht elastisch ist, weil das werden wir nachher sehen. Wir brauchen diesen Gegenzug, dass wir den Arm einfach in der Schulterpfanne halten können. An der Rückseite sieht das Ganze so aus, da sieht man nochmal das hintere Zugband, das man dann auch in der Länge einstellen kann, je nachdem wie viel Zug der Arm braucht oder benötigt. Und auch unten dieselben Klippverschlüsse wie oben sind auch so gewählt, dass man wirklich mit einer Hand auch vor dem Spiegel oder sowas wirklich selber öffnen und schließen kann. Das sieht man auch nochmal das Zugband, das man einstellen kann. Das sind so Y-Krokodilverschlüsse, die man auch dann in der Länge dementsprechend kürzen kann.
Und von der Funktionsweise ist es dann so, dass wir uns wie der Alex auch schon gesagt hat, den Konus am Unterarm zunutze machen, das Ganze dann auffangen, über einen Flaschenzug, über das Band oben, nach oben ziehen und somit die kraniale Bewegung des Oberarms bekommen und somit diesen Lift-Effekt oder den Halt des Oberarms in der Pfanne dementsprechend erzeugen. Von den Features kurz noch, dass wir das nochmal wiederholen. Die Orthese kann mit einer Hand angezogen werden, braucht natürlich allerdings ein bisschen Übung. Also der Patient muss das üben, geht auf Anhieb nicht, aber wenn er das dann, sage ich mal, drinnen hat, dann ist jeder Verschluss auch gleich anzulegen. Dann haben wir eine Größe. Wir haben im Endeffekt die Orthese rechts und links verwendbar, wie der Alex schon gesagt hat. Und wir haben es kombinierbar mit den CDS-Produkten. Zu der Kombinierbarkeit ist es so, wir haben 6 Orthesen in der oberen Extremität, bei der wir dann die omosan und die Orthesen dementsprechend verbinden können. Das eine ist einmal die CDS-Handgelenkschiene, Dann haben wir die CDS-Ellbogenschiene, die CDS-Handgelenksschiene Duo, CDS-Ellbogenschiene Duo, die CDS-Manosan und die CDS-Kombinationsorthese Ellbogenhand. Also das sind alles 6 Orthesen, die mit diesem Produkt dann dementsprechend verbunden werden können. Was man dazu benötigt, ist im Endeffekt ein Verbindungsset. Das besteht, wie man hier auf dem Bild sieht, aus 2 Gurten, wieder den gleichen Clipverschlüssen, 2 Schrauben und 2 Halteplatten, die dann auf der Orthese dementsprechend fixiert werden, dass wir dann dort dementsprechend halt auch das hinbekommen. Und das Bild haben wir ja vorher schon gesehen. So schaut das Ganze aus. Man kann das Ganze auch dann dementsprechend tauschen. Das heißt, wir können die Orthese raufgeben oder eben auch den Unterarmteil. Und jetzt darf man sagen, das einmal her. Der Herr Metzler würde mir die Orthese anziehen und dann hätten wir Orthesen dabei, dass wirklich jeder, der das mal spüren will, den Effekt einmal spüren will, dass wir das dann dementsprechend einstellen können.
Man kann dazu sagen, die omosan kann mit jeder CDS-Orthese auch jetzt schon verbunden werden, weil entweder bei den Ellbogenorthesen sind dementsprechend schon Löcher oder Bohrungen im Oberarm drinnen und bei den Handorthesen gibt es dann spezielle Bohrschablonen, wo man einfach dann die Löcher setzt. Das heißt, man braucht dann nicht irgendwie auch nochmal eine neue Orthese, sondern jede aktuelle CDS-Hand-Ellbogenorthese kann man dann nur mit dem Verbindungsset dementsprechend verbinden dann.